Good.
Yeah.
Hi, I'm Nechama Dworkin, speech language pathologist at the Voice Box Speech Therapy Clinic in Montreal. And I'd like to welcome my very special guest, Dr. Ina Husain, ear, nose, and throat specialist, who's an associate professor and section head of laryngology at Rush University Medical Center in Chicago, where she treats patients with airway, swallowing, and voice disorders. Thanks so much for taking the time to chat with me today, and welcome, Dr. Husain.
Thank you. I'm so happy to be here.
Today we're going to talk about benign growths of the vocal folds, such as nodules, polyps, and cysts. So if you could tell us a little bit about what are they, where do they come from, and then what can we do about them once they're diagnosed?
Sure. So, when we talk about benign vocal fold lesions, we're talking about a variety of things that we can see on the vocal folds. Most benign vocal fold lesions are caused by what we consider phonotrauma. So, it's the act of speaking or the vocal folds vibrating up against each other that can cause them. Now, there are some benign lesions that are not caused by phonotrauma, and we won't really be focusing on that today, but that would be something like papilloma, which is more of a viral mediated disease. So, with regards to kind of phonotraumatic lesions, I think the first thing to understand is really kind of part of how voice is produced, right? So, on a very simplified level, essentially what happens is the vocal folds have to vibrate up against each other and make contact. So, these phonotraumatic lesions we often see, for example, like nodules on this area of contact, so on what's called the vibratory edge or the medial edge of the vocal folds. Vocal fold nodules are one type of benign lesion. Other ones include things like vocal fold cysts or vocal fold polyps. Those would be kind of the three big categories of lesions that we see.
Okay, and what would be the difference between nodules, polyps, and cysts, if it would be possible to explain that in a nutshell?
So a lot of times the diagnosis is based on appearance. And so if you do enough of these video stroboscopies, you get really good at diagnosing based on how it looks. Now, what's interesting about laryngology, it's kind of a well-known joke that terminology in our field is sometimes all over the place. So there's actually been studies on this in terms of what do you call that little bump versus somebody else, right?
Yeah.
So I'll tell you that one of the things that I personally believe is that it doesn't quite matter what you're calling the lesion. It's more kind of knowing the best way to manage when you do see that type of lesion, right? No matter what you call it. So when we talk about vocal fold nodules, classically we're talking about bilateral, meaning things that are on both vocal folds and usually opposing each other, so opposite. So think of it as like two contact points where the vocal folds are meeting. We often find them in the area known as the striking zone, which is actually an area of maximum contact between the vocal fold edges, usually about a third of the way back from the front. Vocal fold nodules also have kind of terminology known as kind of kissing nodules because they kind of make contact. They're also known as singer's nodes. And essentially what they are is just think of like a callus on the vocal fold. And I think that analogy is actually really helpful for patients to imagine because you know a callus is kind of like thickened skin. It's not as soft as the surrounding area. And that definitely has implications for the sound or the quality of the voice that will be produced because that area vibrates differently than normal vocal folds. So nodules classically always have a buddy on the opposite side. Now, polyps are different. Polyps usually look like almost like little balloons on the edge of the vocal fold. Sometimes they can be on the surface as well, but classic vocal fold polyp is on the edge, a little bit of a balloon. It may be red if it's filled with blood, or it may be translucent or clear. These are usually one-sided, so you usually don't see polyps opposing each other. But if you look hard enough, you will always find a contact lesion on the opposite vocal fold. So that's something when we're
Interesting.
training people how to do video stroboscopy, always look for that contact lesion because it's important for patients to see that when you make their diagnosis. So that's what kind of a polyp is. Now, a cyst is a little bit different. Cysts are usually located underneath the surface of the vocal fold. So you'll actually, sometimes you can see very obvious, almost like a marble under the surface. And depending on what the consistency of the cyst is, it may be somewhat more translucent, it may be somewhat more yellow, depending on that consistency. Couple of things that we think cause cysts. So again, going back to the anatomy of the vocal folds, we do have mucus glands that are in our vocal folds. And if you think of a mucus gland as getting plugged, it could turn into like a cyst. So how would a mucus gland get plugged? Well, phonotrauma, right? If it hit the gland hard enough, it could potentially start to get blocked and fill with mucus and turn into a cyst. So we do think phonotrauma has some origin in vocal fold cysts as well. Now, interestingly, with the cyst, they can also be congenital. So maybe there's some abnormal tissue or glands that were there to begin with. But usually you can think of a congenital cyst more in terms of how long it's been there and the symptoms. So they can be congenital. Unfortunately, there's really no way to test for that. So we wouldn't know at the time of diagnosis.
Okay. Okay. Thanks for that explanation. That's awesome. And what did you call them? Kissing nodules?
Kissing, yeah, like kissing
I,
lymph nodes. So they come together right there.
Yes, I've never heard that one before. I like that. And, it's interesting that you mentioned the analogy of a callus because I try to explain the anatomy, to my clients as well as I can. And I often explain to them that, first, when there's phonotrauma, it starts with swelling of the vocal folds. And then I explain to them exactly that at the point of most contact, they start rubbing together, and then I tell them that it starts off as a blister. I don't know if that's accurate, but that's sort of how I say it to them, is that it starts off like a blister, but then if they continue rubbing and rubbing and rubbing, it turns more into a callus. Is
Right.
that
The skin, the epithelium essentially reacts to localized inflammation. And the term
right?
inflammation, we use it very often, but it doesn't necessarily mean that the area was infected or horribly swollen, but it's just a reaction. So the tissues
Oh,
react to that. And how
okay.
does tissue kind of react? It can kind of thicken.
Okay.
So it's protecting against a little bit of that pressure.
Right. Interesting. Okay, and then what are the treatment options once a person has a diagnosis of nodules or cysts?
So for kind of, I generally for kind of all of these phonotraumatic lesions that we're talking about, I tell patients their options are kind of the same. So one option is always to do nothing, right? This is quality of life. This is definitely your choice. Some patients just need to know what's causing the symptom, but don't really want to do much about it. And that's perfectly reasonable. Okay, so most of these benign vocal fold lesions, we use the term benign because we do not think they're cancerous or malignant, unlikely to significantly grow to cause problems with breathing or swallowing or significant pain. But if left untreated, they need to understand that they can have worsening voice, further damage to the edges that can happen. So, one option I always tell with patients is you can choose to do nothing. It's completely your life, but just understand the risks of not doing that. Next up, I like to move up in terms of like a ladder, in terms of intensity or invasiveness. So, the second thing I talk to patients about is actually voice therapy with our speech language pathology team. So, if we call these lesions phonotraumatic, we have to understand that likely they were caused by the way the patient was using their voice. Now, this can be chronic issues, or maybe it was one really bad yell or throat clear that caused a polyp to develop, but there'll be some implications for how the voice is used. So voice therapy is classically used, especially, for example, with vocal fold nodules, and it's considered the gold standard for treatment, right? So analogy I give to patients with regards to that is if you have a callus from a new high heel that you've been wearing or a new sandal all summer, is the first thing to cut it off or is the first thing to change the shoe, right? And I
Oh,
think
I
that kind
love
of
that.
hones in on that idea. Like I would change my shoe first, right? So changing your shoe is like changing the vocal techniques that you've been using. People cannot do that often on their own. So you need guidance from a speech language pathologist to help you figure out how to do that for yourself. So usually voice therapy, especially if it's nodules, it's kind of my primary intervention that I recommend. Next, we start moving up in terms of invasiveness. So for some of these lesions, especially if I see kind of a lot of swelling and that sort of thing, I'll talk to them about trying an in-office steroid injection. So the idea behind this is to essentially inject some steroids, which are anti-inflammatory, locally, meaning in the site of where the inflammation is happening. So I have definitely done this even for vocal fold nodules. For example, in patients who are teachers and they cannot take any time off during the school year, but they're really struggling. We can do an office procedure where we inject some steroids just to buy some time, essentially. I would never promise that the nodules would disappear, go away with steroids, even serial steroid injections, but it's a pretty minimally invasive intervention that can have some potential benefit, especially if we're trying to buy some time, right?
And it shrinks the tissue. Is that what it does?
Yeah, the idea is just to help decrease some inflammation. So it doesn't melt away the nodule, but as you know, if you have a nodule and you have phonotrauma on top of it, you're going to get some swelling that's going to precede the nodule physically getting bigger. So the steroid helps with that active inflammation that can happen. Okay.
Okay.
And for a variety of medical conditions, steroids are actually used for scar modulation. So when we think of things like keloids, the idea is serially injecting the steroids can help modify the scar formation. So, there is some benefit in using it for nodules, which we think is a form of scarring.
Okay, that's all new to me. I've never heard of any of that, and I've never had any of my clients come to me. Yeah, so that's
Steroid
fascinating.
injections, yeah. And then
And what are the risks in terms of steroid injections?
not too many. I mean, the procedure we often do in the clinic situation where patients are completely awake, so no general anesthesia. We just give topical kind of gargles of lidocaine. I like to go through the nose with a channeled scope, so there could be a little bit of, discomfort in the nose, a little bit of anxiety associated with the procedure. You want to inject superficially, so you're kind of aiming for that superficial lamina propria. Theoretically, if you were to inject into the muscle and do this serially, could you have some atrophy of muscle? Possibly. But again, people aren't getting 10 or 12 of these, maybe one or two.
Yeah.
And again, do it very superficially.
Okay.
So no major risks associated with it.
Okay.
And then surgery. So surgery is kind of, again, moving up that scale of invasiveness. Surgery would be essentially cutting out the lesion. And that can mean different things for different types of lesions. Generally for nodules, we really reserve that for really severe cases. For things like polyps, size sometimes will dictate that, what the patient's, profession is, how quick they need to be in recovery. And then cysts often do need surgery. So most cysts will end up needing to be surgically removed because, again, we don't know if it was truly a congenital thing or if that gland has really been damaged. Voice therapy is less likely to be beneficial for that.
Okay. And then post-surgery, what can people expect in terms of
Sure.
recovery period and recommendations for voice rest and so on?
Yeah, so all of the surgeries for all of these lesions are all considered endoscopic, meaning we go through the mouth, so there's no external incisions. They are done under general anesthesia in an operating room. So patients, usually most of us, I think, can do these in under an hour. So they're usually quick outpatient surgeries, meaning plan would be to go home the same day. In terms of expectations for recovery, so because it's under general anesthesia, some amount of a little bit of nausea, feeling fatigue is quite common for up to 48 to 72 hours afterwards. In terms of physically, patients will feel some amount of sore throat. It can vary depending on how long the case, how small the mouth was, how big of a scope the surgeon had to use. But generally, sore throat is to be expected. Most patients, I tell them it'll feel like when you're getting a little bit of a strep throat or a cold, that type of soreness. Patients generally should plan to eat kind of softer foods, just titrated to comfort. So if the throat hurts, you don't really eat, big spicy meals and things like that. Voice rest can vary from surgeon to surgeon. So I know people, when I was in training, we used to do 2 weeks of voice rest, which is a really long time for most patients. And then I know other surgeons will do about 3 days. I personally found kind of a happy medium with about a week. Most
Yeah.
people will take some time off anyway, so a week doesn't feel that long. And then I usually get my patients into post-op voice therapy to help with recovery. Ideally, if we could do it pre-op would be great, but the logistics of real world living sometimes just does not allow that. So then we'll try to get them in for a session or two afterwards, depending on, how they're doing. And I usually start that at week 2.
Okay. All right, yeah, a week sounds reasonable to me. When I hear more than that, I get a little taken aback and I'm like,
Right.
what? You didn't speak for a month?
No,
No
for sure.
wonder you need to see me. Yeah. And so I guess I have one last question for
Sure.
you about children. So often I hear patients or the children's parents coming to me and telling me that the ENT says that they will outgrow their nodules. So, what's your feeling? What's the difference between children and adults? Do they outgrow nodules? How do you feel about that?
Yeah, so I'll tell you, I mean, we come across patients a lot who will say, I've had a raspy voice forever, right? Like
Yeah.
everybody in my family knows I had a raspy voice. So basically, they're describing what sounds like childhood, probably nodules or a phonotraumatic lesion. So I think the idea of outgrowing it, I think the way to think about it is that as we get older, our larynx definitely grows, right? And part of that growth involves lengthening of the vocal folds, right? So an adult vocal fold is much longer than a child's. So if you have a nodule and the surrounding tissue gets longer, the impact of that nodule will be less. And that's simply kind of a surface area to length type of issue.
Stretching out.
Correct. So I don't think it's necessarily like you're growing out of the nodule. It's simply that the surface or vibratory edge has now lengthened. And so the amount of thickening there, if it were to stay stable, is less prominent in terms of the symptoms that it can cause. I still, if vocal fold nodules are identified, I would say I still would recommend, voice therapy, because why not try to address some of those issues, because again, they can get worse, right? And the longer scarring is there, the longer you have inflammation, the harder it will be for that to become symptomatic in the future.
Okay. And actually, I have one last question
Sure.
because my clients often ask me this. So people ask me just in voice therapy, but and I have my way of answering them. But they say, well, let's say I go for voice therapy and the nodules dissipate and there are no more nodules. Aren't they going to come back?
Sure.
So
So I will tell patients it is quite possible for vocal fold nodules to come back or for you to develop another lesion, right? But it's not the actual nodule that came back. So it's not that that nodule grew, it's that you caused trauma again. So it's, again, the nodule is not a tumor, it's not cancer, it doesn't have kind of self-propagating potential where it will kind of grow unchecked, but you can re-traumatize your vocal folds, right? And so that's why learning these techniques early is so important, and why we kind of advocate against rushing to surgery, right? So if you identify a lesion, especially vocal fold nodules, I will never offer surgery at that first visit, because that is inappropriate, right? Because we haven't kind of taught the patient different techniques to help prevent this from coming back, right? And
agreed.
the more
Yeah.
time you operate on vocal folds, you are inducing scarring to a certain extent. So if you want to have the best possible outcome, you want to help eliminate factors associated with voice use. And so, again, it's not that they grew back, it's that you re-traumatized the vocal folds.
Right. And what I tell my clients is that, I'm going to provide you with a toolbox full of strategies and knowledge. I always say knowledge is power. So before you had no idea why your voice was hoarse and what caused the nodules. But now that you know what the cause is, what to do and what not to do, and they're become more aware of the feeling and the sound of their voices, then I say, once you feel it coming on again, you're going to know. If you feel that hoarseness, as soon as you feel that discomfort, figure out what it is that you've been doing, rest your voice, take vocal naps, drink more water, whatever it is, just reach into that toolbox in
Right.
order to prevent it from getting back to the point of being nodules again.
Right. And
Yeah.
I will add one point kind of with that we didn't really touch on, but I think is important. is, we call these phonotraumatic lesions, meaning the use of the vocal folds or use of the voice contributed to it. But we have to remember that some people are just naturally more susceptible to this type of damage, right? So you can have the same amount of voice use perhaps as your best friend, but you develop nodules and they don't.
Such a good point.
And
Some
so
people can like literally get away with murder. I
right,
said my
exactly.
husband can scream and sing and talk and nothing, nothing.
And some of that has to do with anatomy, right? So why can babies scream on end without hoarseness? They have more SLP, right? More buffer, more protection. Some people are just born with less of that, right? So that's where you
Yeah.
see your focus sulcus change, early focus changes. I will tell you medical conditions can definitely contribute as well. So if people have really uncontrolled sources of inflammation like allergies, asthma, reflux, makes you more predisposed to getting inflammation at the level of the vocal fold, which will be exacerbated then by voice use. If patients are on things like blood thinners, they're going to form a hemorrhagic polyp with a throat clear more commonly than somebody who's not on blood thinners. So there are medical conditions that can exacerbate the phonotrauma. But I also always like to say, show me a librarian with vocal fold nodules.
Right.
Show me one. Because you can't get these lesions without phonotrauma. So,
Yeah. 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 Excellent. All right. Thank you for adding that.
yeah,
So, I want to thank you so much for joining me today to talk about benign vocal fold lesions and what's involved in treating them. And I would love to talk again soon about some other topics that would be of great interest to my clients who are experiencing different difficulties with their voices.
definitely would love to.
All right. Awesome. Thank you so much.
Take care.
You too.